Today, I'm going to talk at you about using the sepsis tool for easy and organized adherence to the sepsis treatment protocols here at Shawnee Mission Medical Center. Well, it's not just me. There's a pretty big team helping me. Sepsis, serious complication of infection. When an infection hits the bloodstream, it can lead to systemic inflammatory responses throughout the body that can lead to shock, respiratory or cardiovascular collapse, acute multi-organ system failures, and even death. Telltale signs have been identified and are essential in the recognition of sepsis. Shown here are the symptoms of systemic inflammatory response syndrome. Any two of these, and we're talking bad news. If you couple two of these with an infection, that is signaled for sepsis. If you take that a step further and you notice any two of these shown on screen, plus an infection or risk of infection and acute organ dysfunction, that is known as severe sepsis, and some symptoms of these are shown below. Now keep in mind that not all patients with an infection are septic, and not all infections lead to sepsis. The purpose of early recognition is to determine if that is the direction the patient's condition is going. Early recognition and treatment has been shown to improve patient outcomes and effective care of septic patients. That is why, here at Shawnee Mission Medical Center, we've adopted the 3 and 6 hour care bundles. From the time a patient with an infection shows 2 or more SIRS criteria or any of the organ dysfunction criteria shown just now, time it. This is known as time zero, and the start and precise timing of every treatment from here on in is essentially launched from that moment. For those of you in the emergency department, time zero is known when the first net places a bug icon on the patient. You can see a picture of this below. On any other unit, including patients already in the ICU for treatment of other conditions, this time is when the sepsis screening tool completed each shift flags a patient and the notification of the provider ends in diagnosis of sepsis. The interventions and treatments for septic patients fall into the 3 and 6 hour care bundles from this time zero specifically drilled into you, the nurse, because we all know you're some kind of superhero patient-saving guru. But doing these things effectively and timely in the acute care business can get hectic, especially when this is not the only patient you have to look out for. It is for this reason that a previous cohort revived the clinical sepsis tool. Yeah, the green sheet available for your review before this presentation. Did you print it out? No? Let's fix that. Go ahead and pause me, check out the link attached to the page. I'll wait, if you promise you'll come back. The following scenarios are going to outline some weaknesses that we've identified in the use of this sepsis tool and the treatment of septic patients. These scenarios honestly happen a lot more than I'd like to admit and are no one department's flaw. We are a team, and both the ED, who identifies these patients in, and the ICU, who receives a majority of septic patients, are equally responsible for the use of this tool. On the floor, I didn't forget about you either. Hold each other accountable, because using this tool during treatment and then handoff, the patient is getting the best care and we are making each other's lives easier. It's just that simple.
I don't even know where the green sheets are. How am I supposed to use something that I can't even find?
You know those folders where all the forms are kept on the unit? It's the green one. The only green one. A lactic acid level acquired and the reflex timing must be recorded and communicated in transfer of patient care to the receiving nurse, especially if that nurse needs to draw the reflex. Don't forget that our new policy is to draw a reflex twice, 2 hours apart from each other, if the lactic acid continues to be greater than 2 each time. ICU nurses, you can put this lactic acid for the use of the sepsis screen if it hasn't been drawn within 48 hours per policy. But all nurses can enter these labs as written by the provider if the order set populates when we begin sepsis treatment. That means if for some reason the lactic acid reflex doesn't populate, put it in. It's your responsibility. This is literally a breach of both protocol and the safe practice for the patient. How can we get a positive ID on an infectious organism if you have already contaminated the sample with a drug that kills the bacteria we are trying to find? Start IV access if there is not any, or use a butterfly needle. Just get at least one set of blood cultures. On that note, some providers will call for 2 sets, 15 minutes apart, from 2 separate draw sites, as this is widely accepted as best practice. Remember, if you don't document your actions, it doesn't count. Scan them both and send them down to the lab. Crunched for time? Draw a set, scan it, draw a second, scan it, then send both. Oh, and make sure that you draw these before we start antibiotics and you scan them before the antibiotics. Proof is in the pudding. The Cerner pudding.
Docent infuses over 4 hours. She needs therapy ASAP. I only have one access, and Vank is over an hour. 1 hour, 4 hours. 1 hour, 4 hours. The bundles are based on hourly timing, so I should put in the faster one.
Remember that list of pre-approved antibiotics? Yeah, the one on the green sheet. Those have to go first. Vancomycin is not on that list. Zosyn needs to be administered first in this situation. Now, a lot of those antibiotics that we have approved infuse over a much shorter time than Zosyn. But guess what? You can call the pharmacy, give the FIN, and ask for that dose to be retimed to a 30-minute infusion for a septic patient.
Hey, John. Yeah, Lauren in the ICU. Calling about Mr. Rogers in room 475. This patient is septic, and I need to give that first Zosyn dose as quickly as possible, and my access is pretty limited. Can we get that changed to the 30-minute infusion? The original order came from Dr. Zeppelin. Yep. Thank you.
Now, research says Zosyn is more effective over 4-hour infusions. But hey, this is a time situation. Crank it in there over 30 minutes, then the Vanc, and then later doses of Zosyn can be retimed to the 4-hour infusion work. The fluid resuscitation is an important part of sepsis treatment if a patient has a lactate greater than 4 or is beginning to show signs of hypotension. If this is the case, shock could be on the way. Don't wait. Fluid bolus should be calculated at 30 milliliters per kilogram and conveyed to the provider. You need to calculate this out and get it running. But you also need to scan the bags. The best way to do this, because bolus orders drop off after 60 minutes, is to scan all the bags being given, label them, hang them up, and then communicate which ones are being administered during handoff. When done this way, the MAR shows the bolus was initiated, like the documentation needs to show, and the receiving nurse knows when to stop the bolus and get orders for maintenance fluids as needed. 2 outcomes are possible when this bolus administration is done incorrectly. Not enough fluid means the patient could continue into hypotension and progress into shock. The flip side, we give too much fluid and the patient goes into fluid overload, possibly causing pulmonary edema, congestive heart failure, even kidney damage. Don't be the reason a person gets worse, be the reason that they get better.
So the patient has had the lactic acid drawn. She had a 4.6. The first reflex should be in a second, and her second will be at 22:30. We went ahead and started her on a fluid bolus. She's had like 2,500.
Handoff is essential. You show the calculation by weight to the oncoming nurse and know precisely how much fluid has been administered. Bag still hanging? Good. Explain which bag that is and where that lands us on the bolus total. And you, if the calculation isn't offered, ask for the clinical weight, do the calculation, and then ask where we're at. If there was a reason the full bolus hasn't been ordered, ask why. Both parties are responsible for this patient's life and treatment. Don't get an attitude, just be an effective transfer of care. So what's the point of all this? All these measures that we've been talking about over the course of this video, yeah, they're on that green sheet, in order, right there. Research shows if you use a list-based tool in enacting systematic interventions for sepsis treatment, outcomes are better across the board. We also see major increased efficacy in handoff report and transfer of care when we follow a systematic approach. So pick that sheet up, fill it in as you go. Make sure you put the times as you complete each of the interventions. This is essential. It's there to make your life easier and the records for treatment more accurate. During handoff, use it alongside the brain sheet you have glued to your pocket and hand it to the next nurse during transfer. That means from one unit to the receiving unit or from one shift to another. It does not matter. Here is how a transfer should look.
So we've got Mr. Siegel here, 45-year-old male with previous history of hypertension and DM type 2.
Okay.
Reported to the ED feeling shortness of breath and looking pretty pale. We took his vitals. Temp was 102, respiratory rate 35, heart rate 164, and blood pressure 84/36.
Okay.
Even though he was walking and talking. We coded him out of septic with a 0 time at 1450. I went ahead and drew his lactic acid, came back at 2.2. Reflex will be due at 1545. Both sets of blood cultures have been drawn and sent to the lab, and the Zosyn is hanging now. And you've got Vanc and Cefepime ordered. The patient has a weight of 87 kilos, so the fluid bolus calculated was at 2610. The last bag of normal saline will be at his goal.
Any maintenance fluids?
Not yet. Dr. Hans wanted to cheat of the patient plus post-bolus and then called him for orders.
Sounds good.
See? How simple was that? And even if the patient was brought down from another unit to the ICU in a rush, as long as we have a time 0 and the steps have been completed up until this point, the handoff communication should flow just as effectively. And you can literally hand the next nurse the checklist. As long as you put the times on the sheet, they can pick up right where you left off. Sepsis is serious, and it needs to be taken seriously. But tackling that problem isn't something we do alone. It can't be. Communication is key. I get it. The ED is chaotic. It's a whole different animal. Keeping it all straight can be extremely taxing. And no, being an ICU nurse doesn't make you better than everyone else. I would know. Floor nurses, you need to be aware of these signs too, because let's be honest, if a patient rolls over into septic shock and it isn't recognized and treated, that's on you. The goal is to give our patients the best possible care. To do that, we need to follow these protocols backed by evidence and help each other out. Using this tool is made simple to make the rest of the process as simply organized as possible, so you can focus and put that focus into the hardest part, like the impossible stick or the patient throwing a fit next door or catching up on your charting. The only thing standing between a positive and negative outcome is you and your team. So be a team.